Hi everybody, and welcome to Scottish Autism. A very warm welcome back to Professor Jason Leitch, the National Clinical Director. Hi Jason, how are you doing?
I'm doing fine, I think, although the weather outside this window is absolutely wild. But yes, I'm glad I'm indoors with central heating.
Yeah, we're certainly getting tested today, but brilliant to have you back. We're going to focus today a bit on vaccination and people's questions, worries, concerns around that. So the way we're going to do this is Jason's going to give us a sort of 10-minute kind of overview of the vaccination, what it's all about, and we've had some pre-submitted questions which we'll work through, and then we'll also be trying to take questions from our live Facebook feed. So a bit of a challenge for me because I'm not generally very good at switching tasks, but we'll try our best. So over to you, Jason.
Thanks, Charlene. It's great to be back. Thank you for having me, and hello, everybody. I'm sorry you've perhaps had to give up your lunch break for this, but I'll endeavour to keep it as light as we possibly can and to answer as many questions as I possibly can. And all I can tell you before I share some slides is that I'm sorry I don't understand your context, because I can't. You don't understand mine. So I don't walk in your shoes. So forgive me if I get the language wrong or if I sound unsympathetic. That's not deliberate. I absolutely promise you. And the other thing I can tell you is I'll tell you the truth as I know it today. I've got a lot better when I'm on the TV of saying the date out loud, because the media has a habit of saying, well, you said, and then you look back and it was 4 months ago. So I'll tell you the truth as we know it, reaching the end of February 2021, which will be different, of course, from some of the truth a year ago or some of the truth a year from now. So I'll endeavour to answer your questions as well as I possibly can. Let me just.
That's appreciated. I'll just slope off just now.
Let me share that. So Charlene, you should see, if you can just give me one more word to say, you can see slides just to reassure me.
All good.
So let's very quickly talk about what vaccination is, and then what Scotland is doing about COVID vaccination, and then we'll come to questions. So vaccination discovered by Edward Jenner 200 years ago, when a small child famously was given a little tiny piece of cowpox virus and didn't get smallpox. That's the basic story. And smallpox, of course, was a huge killer around the whole world for decades, centuries, now eradicated from the world as a result of vaccination. It is the single greatest health invention ever. It has saved more lives than any other health intervention, probably other than clean water. It is safe, it works, and it is relatively inexpensive for what you get from it, although COVID vaccination has, of course, been hugely expensive because we've done it so quickly, and we've had to do it faster than usual, and I'll describe that to you and how we did that in a second or two. But let's think about what vaccination is and how effective it is in dealing with those diseases. So this is just 3 examples. It's just a neat way of thinking of them. The top one is diphtheria, a disease that is now eradicated from most of the world. You can still find it in some poorer parts of the globe, but pretty much gone. We introduced vaccination in the early 1940s, and by 1965, the cases are done. Whooping cough, again, introduced a vaccine in 1957, and we still get a few cases, and we still vaccinate against it, in fact. We no longer vaccinate against diphtheria unless you're traveling to a country where there might be some cases. And then measles, probably the one you'll recognize and understand most, a real horrible disease. I mean, a real killer, particularly of young people. And vaccine introduced the year I was born in 1968, took a while because it had to be global, and it's a nasty virus. If you think COVID has an R number of about 3 if you don't do anything, measles has an R number of 18 if you don't do anything. So very, very infectious. That's how it rages through classes when some of us were younger than we are now. And it pretty much gone from the world by the mid-2000s, but unfortunately reintroduced because of some vaccine hesitancy And now we're dealing with outbreaks of measles for the first time in my clinical lifetime. We are now seeing more cases of measles. It's begun to cut back again as people have begun to get their kids vaccinated. It works, and it is very, very safe. Let's think about what it is briefly. So you'll have seen the cartoon version of the COVID virus. That's the red globe. It actually looks quite like that under the microscope. It's not red, but it looks quite like that globe with little spikes sticking out of it. And the little spikes are important because the little spikes are the bits that attach to your cells. The viral DNA, the viral genetic material, then gets into the cell. It divides and divides and divides, and you get trillions of the virus and you get sick. And you also then exhale that virus, and that's what makes other people sick. So the spike protein, which is the little bit that attaches to your cells, is the crucial bit. So what the scientists, the clever scientists, have done is they've taken just the spike protein, not the virus. So the virus is not in the equation. They take a little bit of the genetic material of the spike protein, and that's what they put in the vaccine. And when we then give you that into your arm, your body thinks it's the virus. And it generates the immune response to the virus. So it generates antibodies and some cells which kill the virus. Now, it doesn't have to kill anything because there's nothing there to kill because you can't get the disease. All you've got is a tiny, tiny piece of the genetic material of the spike protein, not even the main bit of the virus. But we trick your body into producing the antibodies. And if you imagine those antibodies sitting in wait, so they're behind a rock waiting for the real virus to turn up. And when the real virus turns up, those antibodies are already there, primed to kill it. That's what vaccination is. And that's the final piece of the puzzle. So the antibodies attack the spike protein when it finds it and destroys the virus. It doesn't divide. You don't get the disease. Now, one of the big concerns is how on earth have you done this so quickly? It normally takes 15 years. Well, most of the time is in trials. Most of the time we spend doing vaccines is in big trials. Now, drug companies don't want to invest £1 billion unless they're sure their vaccine's going to work. Because you don't want to build the factories, you don't want to do all the marketing, you don't want to buy the vials until you're sure. So normally in the top line, you do phase 1 trials, phase 2 trials, phase 3 trials. You do them in sequence and you invest a little bit of money over time. What we did for COVID was the whole world came together and invested together. We underwrote, so we guaranteed the drug companies that we would buy their vaccine, and we manufactured the vaccine before the trials were over. Do you see what I mean? So we took a risk that the vaccine might not work or it might not be safe, in which case we wouldn't have used it, but we had it. So when it was approved, we had vaccine ready to go. That's not usually how it works. Usually they wait for approval, then build the factory. We built the factory, then did approval. But what we didn't do was shorten any of the regulatory approval. We just did it all at the same time. So the regulatory approval, which in the UK is twofold, it's the MHRA, the organisation that do drug safety, and the JCVI, the Joint Committee on Vaccination, who tell us who to vaccinate. So those two groups have met twice a week for the last 6 months and are looking at the safety of the vaccine first, and then whether the vaccine works and who you should give it to. So these are some of the top 3 are the ones that the UK now has approved. We've approved the AstraZeneca vaccine, the Pfizer-BioNTech vaccine, and the Moderna vaccine. We don't have any Moderna yet, but we're getting it in April, we hope. But we do have Pfizer and AstraZeneca, and you've, I'm sure, followed the news about where they are and who's getting them and how they work and how well they're working. And very good research yesterday from Edinburgh University about effectiveness, again, showing a massive reduction in hospitalization in people just from 1 dose. And then my final point is about who to vaccinate. So I'm going to be a little bit blunt here. Forgive me for bluntness. vaccination at this point in the pandemic is about saving lives, only about saving lives. It's not yet about stopping transmission. It is about saving the lives of those most at risk of death, not giving it to the people who transmit it most. That's a really important distinction. That will become a challenge, and we will get to those groups. Just now, we're vaccinating in the order of risk of death, not in order of risk of transmission. These are two different groups of people. And the reason we do that is we want to stop the hospitalization, the ICU, and the death from this horrible disease. Now, there are ways of working that order out, and this is it. This is the curve that tells you who to vaccinate first, second, and third. And it is almost entirely based on age. The biggest risk factor for COVID is how old you are. Now, there are some exceptions to that, and they come in at various points. So if you are a health and social care worker, because of those you serve, not because of who you are, because of those you serve, there is a very good clinical argument that you should go before the over 70s. And that's what we did. The Joint Committee said, vaccinate health and social care workers, not to protect them. It's really important. That's misunderstood. The vaccination for the 35-year-old nurse was not to save the 35-year-old nurse. It was to save the 87-year-old dementia patient who the 35-year-old nurse was looking after. You see the difference? And then as you come down the curve, you start to add in people with pre-existing conditions. Now, this becomes a little bit of an inexact science, of course, because risk is not absolute, it's relative and it changes. So in that group, we put in those who are most at risk of COVID death. And that was our shielded group, the clinically extremely vulnerable group. And we did them with the over 70s. Now we're into group 6. Group 6 is our massive group, which is, let me just jump to here. Group 6 is our everybody who is at risk of COVID more than the rest of the average population, and everybody from 16 to 64 in that group. And that group is huge. This is the UK number. It's 8.5 million UK wide. We think it's over 1 million people in Scotland probably, and it's very, very complex. And we'll come to discussion about that. But let me just finish with going back to here. This is why we do it based on age. Now, this isn't true of every disease. So we vaccinate for measles in a different way. We vaccinate for yellow fever in a different way. So the Joint Committee decides what to do with vaccination based on the risk of that individual disease and based on what it knows at the time it makes those choices, of course. But this is perhaps a neat way of just illustrating it in your head. If you are 90, I need to vaccinate 40 90-year-olds to save a 90-year-old's life. So 40 90-year-olds need to get the vaccine to prevent one death from COVID. If you're 52, me, I need to find 40,000 people in your age group to save one life, irrespective of disease. That's the difference. That's why we start with the older age group. And the same equation can be done for extending life rather than just saving life. And again, to elongate life by a year, you have to vaccinate 10 over 90-year-olds or 130 people my age. I've now said that a couple of times. You're probably fed up with me talking about it. And then let's finish with some really positive news. So this is the European vaccination rollout. So this is all European countries and the percentage of the population that are vaccinated. This is now a couple of days out of date, February the 19th. What are we today? February the 23rd. So we're now somewhere approaching 30% of the UK has had its first dose. The European average is 6%. So France, Spain, the European Union have done about 6% of their population. So the rollout in Scotland has been absolutely fantastic. And this is the groups that we've managed to get to. If you look about 4 columns along, you'll see percent of population. So we're done with everybody over 70. We're done with the shielded, and we're almost done with the over 65s. We'll finish them this week. And then we'll move to group 6, which is the hardest and most complex group to get to. So that's where I thought I would stop, Charlene. and I'm happy to take whatever questions you have prepared or have coming.
That's great, Jason. Could you do us a favour? Could you go back to the vaccine slide? Somebody's saying the one with the 5 different vaccines. Could you just pop that up for a wee second while we chat? Somebody's
Okay.
trying to process that, if that's possible.
Let me just see if I can do it here.
I have to say we've got 139 people tuning in, and we're not going to get through all there.
I hope they've not all got a question.
So I'll do my best. So just keep that there for a couple of minutes longer for the lady who asked that, Polly. So hope that helps you out. So Jason, we'll go straight to the questions, and there's a whole mixture. Some people have been asking about they're needlephobic, and what's the advice for that? And maybe allied to that, we've had it submitted, and someone has asked as well about, Alex has asked about people who've got allergies. Are there any specific risks for them?
Yeah, they're both excellent questions. So let's deal with the needlephobia one first. One of the downsides of doing it so fast is we just wanted the vaccine quickly. So whatever the factory could do, that's what we wanted, because we wanted to get it into care homes just as quick as we could. And you've seen a 62% reduction in care home mortality just in the first couple of months of this program. So every week mattered for that, particularly that elderly group. So that meant, unfortunately, it came in big vials, not very user-friendly. If you haven't looked on YouTube for some of the pictures of these poor pharmacists who had to unload these things from the freezers with big welding gloves on, it doesn't come in a neat little packet with a wee syringe that you just peel off and already diluted. So unfortunately, the version we're getting just now is pretty old-fashioned. It comes in a vial. You have to mix it. You have to then divide it into individual doses because it doesn't come in single doses yet. And it doesn't come with a syringe attached. So all of that will come. And all of the companies are doing that. And one of the things that all the companies are working on is other modes of delivery. Just now, I'm afraid we have no other mode of delivery. It's a needle. It's a tiny needle, and it doesn't have to go in very far. But still, it's a needle, I understand. But eventually we'll have nasal sprays like we have for flu, for kids, and for other people. That'll all come. But for now, I'm afraid the news is needle or not, I'm afraid. The allergy question is a good one. If you remember right at the beginning of the program, the Pfizer vaccine caused a couple of nasty allergic reactions in the initial rollout. It was people who had had drug reactions previously, and fairly severe drug reactions previously. So it wasn't like completely out of the blue, somebody got an allergy to the Pfizer vaccine. So now, as a kind of belt and braces, what we've done is people with severe history of allergy, they are being put in the AstraZeneca box. People with mild allergies, penicillin allergies that haven't been too bad, or hay fever or asthma or any of these other things, can have either vaccine, and they're kept a little bit longer. There's a conversation with them. Nobody's forced to have anything, and they're consented properly, and they get the vaccine that's available. Remember that vaccination is a healthcare intervention. It's not done without speaking to you. So we don't line 100 people up and come along and just with a big needle. There's a healthcare conversation with every single person who has the vaccine. So there's a consent, there's answering any questions you might have, all of that happens. Sure.
And maybe people who've got problems with needlephobia could maybe contact our advice line as well, and we might be able to offer some emotional support with that and practical support too. It's a bit more specific about an autistic adult with a learning disability. Will they be included in the priority group of those aged between 16 years to 64 if they have underlying health conditions? But we got good news about learning disability yesterday, didn't we?
So we did. It's a little bit complex. So the headline news is yes. So people with a mild, moderate or severe learning disability will be included in group 6. Now, it's important to remember group 6 is huge, and we don't have enough vaccine to do 1 million people tomorrow. So although it's hard, Frank might have to wait until Mary gets her vaccine, or the other way around. So you're still going to have to be a little bit patient. But we've said we're going to get to pretty much all of those 9 groups by the mid to end of April. So that's not that far away. Then we're going to do the whole adult population, so everybody who's left by the summer. So the reason I'm hesitant, or the reason I'm pleading, is don't all phone the hotline tomorrow and say, I've not had my vaccine, because you're not due it yet. We're coming for you. We're going to do all carers. We're going to do all of those 16 to 64, and then we're going to have to do everybody over 50. So there's quite a lot of people. I know everybody's impatient, and I think that's great. I think impatience for the vaccine is terrific. I'd much rather be dealing with that than people who don't want to get it. So the headline answer to your question, Charlene, is yes, but still some patience required.
Sure. Just while we're talking about sort of vaccine practicalities, Leanne has asked, and we've had this a lot about adjustments that might be made for autistic people. Leanne's son normally has to get his flu vaccine at home because he won't go into the health centre.
Yep.
What kind of arrangements can we expect for people who, autistic people who won't be able to manage that sort of change of environment? Will it be possible to get a vaccine at home?
Yes, but so the answer is always longer than the headline, isn't it? So if it's possible to go to a mass vaccination centre, whether that's Airdrie Town Hall or the Caird Hall in Dundee or even the Louisa Jordan, then that's probably going to be the fastest way for you to get the vaccine. It's going to be efficient. There's going to be good parking. It's going to be done, and it's going to be a little bit impersonal. Now, that doesn't always work for autistic people. I completely understand that. Nor did it work for my 80-year-old mum, who didn't fancy that much, to tell you the truth. But she was perfectly happy to go to her GP practice, where she knew the nurse, where she knew the car park, where she knew the stairs, and she knew the people, and they all said hello. So we can make adjustments, but in the main, if you can go where you're invited, that would be best. If you can't, then of course there will be other options for that, but it will probably mean you won't get it tomorrow when you've been given the Louisa Jordan appointment, because it's just more complicated. So GPs will continue to vaccinate people. Health visitors, community nurses rather, will be able to go to homes and vaccinate people. We've done that a lot with, forgive the shorthand, the housebound elderly who can't get to the Caird Hall. But my summary is, if you think you can do it, even with support from your organisation, Charlene, and maybe we're trying to do some online work about what it will look like when you get there, so that people will know, people will have face coverings on, but people will still be nice, and this is what the environment will look like. There will be toilets, there will be parking, but there will be a wee bit of a crowd, but people will be separated, all of that. So if we can make that as open and as easy as we can, then people with autism, I would have thought, some would be able to tolerate that. But if you absolutely can't, then of course, we don't want you to slip through the net, and there will be other alternatives.
Fabulous, that's great. There's someone who wants to know how they can find out what type of vaccine they're getting offered and how they can find out what's in it. That's not in the letter that they get.
So you can only find out which one you're getting on the day you get it, and you shouldn't care. I know that seems a bit harsh, but you absolutely should not care. Just take the one you're given. That's what I'll be doing. I'll be cute. As soon as I get my letter, I'll be taking whichever one I'm given. They're pretty much of a muchness. They're not, they're a little bit different, the technology creating them, but their responses are very good. All of the trials, the margins of error of the trials all overlap. So it's not that Pfizer's better at this and AstraZeneca's better at that. That doesn't seem to be playing out in any meaningful way. You can find out what's on them online, what's in them online. Fundamentally, it's water, the genetic material of the spike protein, and a preservative, roughly speaking. That's what's in them. It's a little bit more complex than that. The vaccine scientists would hate me summarizing it in quite that way. And the thing that people have been allergic to is one of the things we use to preserve it, to keep it so that it lasts a bit of time. Particularly those early ones that came, who had to be frozen solid because we wanted them quickly. So we didn't give them 6 months to work out how to preserve them at room temperature. We said, no, we want it now because people are dying. So that's why there's a little bit of a challenge with the Pfizer one for people with very severe drug allergy. But you can get the exact ingredients online. It may be, that question might be a faith-based question. So that might, the underlying questioner there might be about pork products It might be about, are they vegan? Do they use aborted fetuses? The answer to all of them is no.
Brilliant. That's really clear. And I'm going to online here for Katrina because I think you've touched on this, but it maybe just needs a bit of emphasis. She's concerned about a lottery between the more effective Pfizer and the Oxford vaccine. Is there a big difference in their efficacy?
There is no difference meaningful in their efficacy. One of the challenging things about this whole crisis has been doing the science on the BBC live on the telly. Of course, we're not used to doing that. So when you hear on the telly a vaccine is 90% effective, what does that even mean?
Yeah.
I mean, we those of us. So I'm a surgeon. I'm not a virologist.
Mm-hmm.
So the best way to understand it is if you have 100 people and you don't vaccinate them, let's say 10 of them will end up in hospital if they get COVID. Over here, you've got 100 people who you vaccinate, one of them will end up in hospital. Now, you can't tell which one, and you can't tell if it's high risk, low risk, but you know you've got a 90% less chance. So it's odds, but you can't tell which one of those people will end up in hospital. The other thing we know is that whichever vaccine you get, that stays true. So yesterday we published data for Scotland that said between 85 and 94% protection from either vaccine. So that means the 100 who didn't get vaccinated, 10% will end up in hospital if they get the virus. In the other side, the vaccinated group, 1% will end up in hospital, and that will be one of those 100. So it's not foolproof, but nor is the measles vaccine or the pertussis vaccine or any other vaccine.
No.
But it's definitely better than having COVID, let me tell you.
It sounds better to me. Yeah, that's great. There's a question here. I think you've answered some questions as we've gone, so I'm going to skip about this is particularly people who live in residential care, how soon they'll be able to go out in the community after they have the second vaccine, and they're specifically asking about 20 to 30-year-olds, but I think that's the question we all want to know after we've had our full programme, when will we be able to go out?
Yeah, so that's impossible to answer, but let me give you the guidance for where we're headed. Okay. So vaccines on the day you get them don't do anything. It takes 3 weeks approximately for your immunity to rise on a curve, and then it stays there. Now, one of the things we don't know is how long it stays there. We know that if we give you a second booster dose 3 months later, it will go up a tiny bit and it will last longer. But the first dose actually gets you very high. The second dose elongates the time you're going to be protected. We know that lasts for 5 months because the first person to get it was 5 months ago. We don't know if it lasts 6 months because nobody's had it 6 months yet. So we're living it in real time. So we take blood tests from trial people, from clinical trials, and we see if their immunity has survived. And we can judge that. And we'll keep telling people how that happens. And if we need to give boosters in the autumn, which is probable, then we'll do that. Or maybe in the spring, or maybe once a year. The difficulty is that just now we haven't vaccinated 4.5 million people. So we don't know which one of the 100 is going to end up in hospital. And we don't know if the 100 over here unvaccinated are protected. So just now, unfortunately, vaccination doesn't change behavior. Now that's really depressing. So right now it doesn't change. So I still can't see my mum and dad, even though they're a month after their vaccine, because there is still risk to me and milder risk to them, but still risk. So what we need is prevalence down across the whole nation. And that's what you hear the First Minister say in a couple of hours. She'll talk about getting that prevalence down, and vaccination coming up is part of the way we do that. Then we can start to get more freedom based on that vaccination program. But for now, I'm afraid vaccination doesn't change behaviour.
A long way off then. Yeah, bit of a way off, yeah. We've had a couple of questions about unpaid carers.
Yep.
And them not having the same priority as health and social care staff. Claire's asking, will parents of autistic children be offered the vaccines unpaid carers? And we had an earlier submitted question about, in a similar vein. So unpaid carers, where do they come in
They're in group 6.
Group six.
Two groups of them. The group who get carers allowance, they're the easy group to find. So we know who they are. They're in a database. So they will be approached directly. The second group is the kind of self-reported unpaid carer. Does that make sense? So hundreds of thousands of people who care. Now we need people to use their common sense there, because we're not going to send the cops around to see if you're telling the truth. So, but if you consider yourself an unpaid carer, you will be vaccinated in group 6. Now remember, group 6 is big. It's going to take a while. It's not all going to be next week, as we said at the beginning. But yes, unpaid carers in group 6.
Group 6. Just a wee pause for a wee pat in the back from Alex. Professor, I just want to say you and Nicola, I assume the First Minister, have and still are doing an amazing job through the pandemic. So take that.
Isn't that lovely? We should do that every 5 minutes. You should read one of them out, even if it's not true. Just
yeah. Okay, let me find another one. So there's someone asking, was the vaccine specifically tried on a child on people with learning disabilities, or what they're describing as unique disabilities? Would they have been in that trial cohort?
They wouldn't be in the first phase 3 trials. The first phase 3 trials would tend to be relatively healthy adult populations, but elderly. So beginning to move into the older groupings. The trials now are doing that. They're a much more mixed group. So pregnant women, children, groups that we don't tend to do the first trials in, because once we've proved safety in humans, generally, you can then move into other groups to see how they react. Let's bear in mind here, though, that the basic technology, the basic vaccine technology has existed for 200 years. You do not get the disease, and you do not get long-term side effects. You get short-term side effects because you might get a little bit of a sore arm, or because you get those antibodies that we talked about at the beginning, you might get a little bit of a fever. You might feel a little bit off for a couple of days. Most people feel nothing at all, except where the plaster is and where their muscle is a little bit achy. Most people feel nothing. A very small number of people get a little bit of a headache, a little bit of a fever. Long term, there is no side effect to vaccination. This is not like taking a drug. It's not that kind of statins or thyroxins or these things that we all take, a lot of us take all the time, that can give you long-term side effects. Vaccines do not do that.
That's really helpful. This is quite a fundamental question, actually, is where can you find out what is actually classed as an underlying health condition that might make you eligible? So
if you look on the it's a little bit opaque, but if you look on the Scottish Government website, we've now published 2 letters. I tweeted them just recently, so we can give them to you. Could put them on your website as well. And one is quite a technical letter to general practitioners, to GPs, telling them what the vulnerable group is for COVID. So if you've got some, I mean, it's not that hard to understand, but it's a little bit technical because it's written for the medical community. So in there is a letter that describes what that vulnerability is. There's another one that's for all MSPs, which is a little bit easier to understand and describes what those groups are. In simple terms, it's the flu vaccine group with a few exceptions, both in and out. So learning disabilities in, well-controlled asthma out, just because of risk. So the Joint Committee on Vaccination chose what was in the risk group by studying the clinical trials. So one of the controversial ones this week has been, if you've never had a hospitalization and never had oral steroids for your asthma, you're not in the priority group. If you're just inhaler controlled asthma, you're not considered at more risk of COVID than the general population. Now, that's caused some controversy, but the data supports that, and the Joint Committee have said it. So it's the flu group plus or minus some minor differences.
That's really helpful. Rhonda's asking, will these injections become yearly things like the flu injections? Do you think we'll have to have them every year?
Probably, but we simply don't know yet. We don't know what the virus is going to do seasonally, particularly when it's reduced to low levels. and we don't know what the virus is going to do in terms of mutation. So we know it's going to mutate. It's proved it can do that. We expected it to do so. And when the prevalence is lower, viruses find mutation harder. They love more people to spread to because then they can find new ways of doing it. So when the prevalence is low, mutations are tougher. It's another reason to get the prevalence down and keep new variants of the virus out of the country, which is about travel restrictions, unfortunately, and holidays and international travel of any description. But most of the mainstream public health clinicians think we will have some form of annual, semi-annual vaccination on an ongoing basis. That's a huge exercise, remember, particularly if we have to vaccinate the whole population, because the flu vaccine isn't to the whole population. There's a world in which the drug companies will combine it with flu. So you might get one version. It would have 2 vaccines in it. So we could do everybody in the flu vaccine group quicker. So we're not there yet. But eventually that kind of thing will come. Sure,
that's great. There's a question here from June, and I think the core of the question is about epilepsy. I've got a 17-year-old son who has epilepsy, a learning disability, currently being assessed for autism. Is he okay for the vaccine epilepsy? What's the issue there?
So it's difficult to give definitive clinical advice from a very short history, but from that history, the answer is yes, but there is an individual conversation to be had with that parent and that kid when they go for their vaccine, and that's what you should do. You should go with all of your worries and all of your questions, talk to the person who's going to give you the vaccine, sign that consent form only if you're comfortable. And if that individual can't answer your questions, there will be somebody else in the room who they can escalate it to and get you the answer. So if you're at the Louisa Jordan and you meet nurse number 1, and nurse number 1 doesn't understand epilepsy, autism, and learning disability, they'll have a system for taking that up the chain and making sure that you are entirely comfortable before you make that choice for your kid.
Sure. Aileen has come back to us and saying she's not quite clear as to whether autistic people, I think that what she's asking is that the learning disability people have gone into group 6. Are autistic people going into that group? Do you
not automatically. Not automatically. So it's a bit of a judgment call, Charlene, and that's quite tricky, of course, because autism and learning disability, you don't get a blood test for either of them unless somebody's invented something that I haven't discovered yet. So I don't need to tell this crowd how hard the diagnosis can sometimes be, and the spectrum on which people sit, depending on what. Epilepsy is a good example as well. Epilepsy is not one disease. It's a big, wide-ranging set of diseases. Yeah. Remember, what we're trying to do here with COVID vaccination is reduce the risk of dying. So therefore, if your risk is higher, you're in the group. If your risk is the same as the rest of the population, you're not. That sounds harsh, but that's the nature. Now, every adult is getting the vaccine. All we're talking about is the difference between weeks and months. We're coming to everybody, but we're just working out what the order of priority should be in order to save the most lives.
So the overarching message is your time will come.
We're coming. I promise we're coming.
Yeah. I think you might want to answer this question because it's sort of I suppose contradicts some of the things you've been saying, so you might want to reassure. Wendy's saying, can Professor Jason answer this question? Why should a young adult with only 0.1% risk from COVID get a vaccine when we do not know the long-term effects?
Well, two reasons. One is we do know the long-term effects because we know that vaccination is safe. Now, there's a little bit of a tricky intellectual jump here because people will immediately say, well, we haven't had COVID vaccine for long. Well, that's correct. But every time we bring out a new statin for heart disease, we don't redo all the statin trials. We know statins are safe. So when you invent a new statin, you can have it. When we invent a new version of insulin, you can have it. Vaccines are not anything like as difficult or as complex as these drugs that we're talking about. So vaccines are safe. So you should absolutely have it. Now, the other part of that equation is why should you have it when your risk is low? Well, that's because I need you to have it because my risk is higher. And this is where population health trumps individual health. So if you are diabetic, I don't care. I care about your diabetes. I care about you having diabetes, but it doesn't affect me. It's meaningless to my life. I'm not affected by you having diabetes. So you have to take insulin. I don't care. I care. Of course I care. I care about your health.
You know you care.
But it doesn't affect me as an individual. You having the COVID vaccine affects me because the higher the population percentage, the more protected we all are. So me getting the vaccine is good for you. You getting the vaccine is good for me. And that's the difference between population health or public health and individual health, where we usually care about the broken leg or the broken jaw or the diabetes. Now we care about population level protection. So that's why I need the healthy adults who have a very low risk of death from COVID to get vaccinated when they're offered.
Citizenship, isn't it? It's caring for each other and
Yep.
coming together. Lindsay's saying, thanks for explaining everything clearly and with honesty. Thank you to Team Scotland for carrying out vaccination promptly and with care. So you can
see, I should just come here for reinforcement and
yeah, I think it's important. You get a bit of a hard time from some people, but not by Scottish Autism.
That's nice of
you. So someone here, Rhonda, is saying, my son and I had COVID at the beginning of December. We are still struggling with symptoms. Will the injection make it worse?
No. The first thing to say is I'm sorry. It's so difficult. And chronic COVID or long COVID syndrome, as it's becoming known, is a real challenge for us. We don't fully understand it. We haven't had time to study it deeply because it's only existed for a few months. We're beginning to get to the bottom of it a little bit more. It appears to be in men more than women. It's often in younger people rather than older people, not universally. And it's people who have symptoms still after 12 weeks. So they can be really stuck with it for a bit of time. Some people have fatigue. Some people have genuine still chest problems or heart problems. So it's a real complex group of conditions that we're getting better at diagnosing. But the vaccine will not make that worse. In fact, the vaccine will protect you from on a longer basis than your own natural immunity. So they'll have some natural immunity from having had COVID, and that's good because the antibodies will be ready, but the vaccine will just boost that a little bit more and protect you from getting it again.
Great. I will need to make this the last question. There's lots of lovely compliments, and if you want to go back onto our Facebook page, you can bask in the glory of that. What's learning disability nursing? She's finding it very, very, very helpful. One of the things that I know has been bothering a lot of autistic people is getting accurate information about, accessible information. How will I get there? Where will I go? All that kind of thing. And there's a bit of work going on, isn't there, just now around getting information to autistic people specifically to reassure them. Can you say just a wee bit?
Yeah. So one of the difficult things about the pandemic is having to work at pace.
Yeah.
And when I talk to you and this group, or I talk to other groups, one of the things we have to apologize for all the time is we haven't quite managed the translation thing like we normally do. We haven't done the stakeholder engagement as much as we wanted to do. And we haven't been able to do what you would, if you had time, you'd do a walkthrough of the Louisa Jordan with somebody commentating, probably with an autistic person helping. We just haven't had time because we've wanted the vaccine so fast. Now we're playing catch up a little bit, but Scottish Autism and the Scottish Government are working together on accessible materials, on what that might look like for young people, for older people, so that we can try and guide people through what to expect, when to expect it, what it will look like. We can't do that for every vaccination centre. The town hall in Crean-Larach will look a little bit different from Ballach, but we can do our best to try and make that as accessible and as user-friendly as we can. And we need Scottish Autism and those with autism and those who live with people then to help us do that.
Sure, absolutely. Do you mind if I sneak in one last one? Because I think this is actually quite important because it's about a mental health issue. I have bipolar. If you've got bipolar, can you get the vaccine? Is there
Yeah, you absolutely can. There is no contraindication for mental ill health and the vaccine. But again, you should talk to the individual who's going to vaccinate you. But there's no There's no overarching reason why you shouldn't.
Well, Jason, thank you so much. I know you're a really busy man. I know you're dashing off. We've had over 150 people tuning in and lots of positive feedback about how helpful it's been. I hope everybody's going to roll up their sleeves and get on with it. And thanks for everything you do, Jason. We really appreciate it. And thanks for taking the time to speak to us today.
Thanks for having me. It's been fun. I look forward to coming back. I hope people have had the answers to some of their questions at least, Shani.
Definitely. Thanks very much. Bye.